give me 1 minute to go over that. She's an attending physician at the same center and serves on several committees of international scientific organizations focused on hematopoietic cell transplants and immune effector cell therapies, including the American Society for Transplantation and Cellular Therapy, ASTCT, and the Foundation for Accreditation of Cellular Therapy. Dr. Otegbeye is talking to us today about learning being a lifelong process, and please feel free to raise your hands any point during this discussion, and she'll be happy to take your questions. On my part, I'm Dr. Gundia, a very common face around here. I'm a pediatric consultant here on the Isle of Wight, and I'm a neonatologist, hence this discussion. So I'll leave the floor to Dr. Otegbeye to take us along on this journey now. Thank you.
Thank you for the introduction, Alaba. And thanks for the invitation to share to you and Tayo and all of the organizers of this program, of this series of talks. Like, as Alaba mentioned, please feel free to raise your hands or something if you want to interrupt me at any time to ask any questions, because I don't have like a formal discussion planned for this. I'm just going to be talking off the cuff about my experience. And so if at any point in time you find you hear something that you're not clear about, please just interrupt and ask instead of waiting until the end. Anyway, so as Alaba mentioned, I am a graduate of OAU Medical School, same year, same class as Alaba and Tayo and a lot of the other hosts that you've interacted with in this series of talks in 2005. And between 2005 and now, it's been kind of an ever evolving, a journey of continuous evolution is what I'd say, as far as learning and as far as not just learning, not just for practice in medicine, but also in life in general, just life skills and self-care skills. Yeah. So it's been, and I think that's kind of why I said, I mean, if I was going to talk about anything at all, I guess I could talk about learning being a continuous process and never ending. I mean, it might sound a bit trite because, I mean, we all know that there's always something to learn, but I think in terms of even just how I've evolved to my position right now or what I do right now, it's been, yeah, a continuous process of learning and learning things that I didn't necessarily think were necessary skills for what I was doing at any particular point in time. But then just because I had learned those skills, it positioned me. I was in a place where I was ready to take on new opportunities or take on new leadership roles or new responsibilities. So as I mentioned, so I finished IFE, just kind of a general overview of my journey. I finished IFE, I left IFE in 2005 or left medical school in 2005 and then did my house job, my internship at OAU THC, OAU THC. And during I guess before I graduated medical school, there were a couple of things that I thought I was going to be doing. I mean, there was a time in my life that I thought I was going to be I wanted to be a surgeon. I did an elective in the UK back in 2003. And out of all of the divisions that I rotated through in that program, it was at University of Leeds. I had thought then that I did a rotation through neonatal surgery, and I was very convinced that I was going to do some form of surgery. At one point, I thought maybe it was going to be neurosurgery, and then, and maybe neonatal. But then in any event, by the time I was back in medical school, towards the end of the program, I started getting interested in immunology. I cannot recall exactly when or exactly what it was that triggered my interest in immunology, but I was interested in immunology from the perspective of the immune response to infectious disease, and some of that immune response to infectious disease, how it correlated with cancer was a little bit of an interest of mine. I didn't really know exactly what it was I was interested in about it, but I knew it was something that I really wanted to explore. And I wanted to do graduate studies because I felt like I needed a bit more research experience. So basic science research applications. So, I mean, the training and the education that I had at the time, I thought was very robust in terms of the general knowledge, but I had an appreciation for things that I could learn in terms of actual applications, so more like bench research. And so I was interested in, so I started looking out for programs in the US for graduate studies. But I mean, like I said, at that point, I was still thinking maybe immunology versus surgery. And then I did my internship in OAU. And I mean, I enjoyed the entire experience, apart from the fact that my father died in the middle of my internship. But other than that, I mean, it was a good experience in between medicine, pediatrics, OBGYN, and surgery. But my surgery experience, nothing to do with the quality of the surgery or anything like that, but my surgical experience, my pediatrics experience was enough to let me know that that was not what I was meant to do. Like neither one of them. I enjoy taking care of children, but I enjoy taking care of children when they are well. And I identified that it wasn't something like taking care of children when they're sick. Kudos to Alaba and everybody else who does that on a regular basis. It was not something that it wasn't going to be one of my strengths. And surgery as well was not something that at that point, in terms of actually working or training as a surgeon, it wasn't something that I thought was stimulating me in the way that I wanted to be stimulated intellectually. And so then towards the end of the internship, I had already concluded that I wanted to pursue graduate studies in immunology. And so I applied for several programs. I applied to several programs in the US, one of which was at Johns Hopkins, where there was an opportunity to do a PhD in immunology. That was kind of a straight to PhD program where you would, with an undergraduate degree or a degree like my MBCHB or the MD degree, I could do a straight kind of the curriculum would cover both masters and then going straight to a PhD. And so I came, and so I mean, I applied for it, just because I said, let's see. And I was invited to interview. And so I came to the US first as a visitor. I think that was 2007. I mean, so I did my internship first and then started youth service as well. So I came to the US first in 2007 on a visiting visa to interview for this PhD program in immunology. And ironically, the program the lab that I applied to, because as part of the PhD, you have to apply for, you're basically interviewed to join a lab. And then you get your whole training in that lab. So the lab I applied to was a lab of a lady, Elizabeth Jaffe, who's still at Johns Hopkins and is, a world-renowned expert in, ironically, what I do now. So with cell therapy, particularly T cells, so T lymphocytes. And it was, for me, I think I was very inspired or very encouraged by the fact that, I mean, my application, I was very clear about the fact that I had very limited bench research experience, but I really wanted to gain that experience. And so I think I was very inspired by the fact that someone took my application seriously, to the point where they would invite me and pay for my trip to come visit at the program for this PhD program. And then, I mean, so a lot of the discussions were very positive, but eventually because it was kind of a straight to PhD program, they wanted people with a bit more bench, even though I said I didn't have bench research experience, so that was already well known, but they wanted people with a bit more bench experience, as well as the fact that the program was funded by an NIH grant, which was limited to certain types of visas or certain types of partnerships with particular countries, or that had training partnerships with the NIH or with the US. So eventually, I knew that it wasn't going to be a path forward, but I still wanted to come to the US and again, at that point, still very clear in my mind that I wanted to pursue more graduate studies. And at the time too, I thought that I might veer off completely from like direct clinical practice into more research and just more science that was related to the clinical space, so immunology. And so I decided instead to apply for a master's in public health program with a focus. The applications I put in were really focused on, I indicated my interest in infectious disease and immunology. And there's a question there and I will stop to answer it soon. But so I kind of applied to multiple programs, and I got offers to 3 that I particularly wanted, first to Harvard, and then Johns Hopkins and Berkeley. And so, but then, the irony of it, I guess, and this is one of the things where the irony of it was that the program I accepted to at Johns Hopkins was actually the MPH in infectious disease and immunology, while the program at Harvard, and I think the same thing was at Berkeley as well. The Harvard program didn't have a master's program that was oriented around, that was specifically designed for infectious disease and immunology. There were PhD programs. But when I was applying to that program, I thought, being in the Harvard community, I would have exposure, I would have access to some of the other departments that I was interested in. And so I thought that was part of the reason why I applied to Harvard. And of course it was Harvard. And before I continue to why I picked Harvard, let me see. The question was, how were you able to convince them to give you an interview without any lab bench experience? Was there anything in particular that you think swayed them? I honestly do not know. I think, maybe I should have looked at my letter of interest or something before this talk to see if there was something in particular there. Just now, looking from the perspective of someone who's been in the academic environment here, and I've reviewed several graduate students' applications and things, I honestly do not know what it was that I put in that application. There wasn't anyone who helped me write the application. I think it was just, I was very clear about the things that I knew and the things that I did not know or did not have access to, and why I thought the program could help me in that respect, and so maybe that was it. Maybe it was just the clarity. I honestly do not know. But in any case, it probably also helped that I had good scores on my what do you call that? The GREs, but anyway. Okay, so now I had 3 offers I had 3 offers that were 3 offers to very good schools. So Harvard, to Berkeley and Hopkins. And like I mentioned, the Hopkins program was actually infectious disease and immunology. And but then I eventually decided on Harvard, and it really was not based on it wasn't based on like a lot of, it mainly came down to when the people that I spoke with, my family and people who knew I was in the process. It was why would you not go to Harvard kind of, and so that's what it really came down to. But then at the same time, I also told myself that part of the reason why Harvard seemed more of a better choice was the opportunities I could have. Johns Hopkins also has a great program. The School of Medicine is great. And so all of the research associated at Hopkins too is also, but in my mind there, just because of our prior experience, or at least what we knew about Harvard, right? My thought was it was a school or a college where I would have access to everything else outside of the department I was affiliated with was going to be top notch as well. So anyway, I have no regrets about going to Harvard or choosing Harvard over Johns Hopkins. I think either program would have been, and I know that I have colleagues here who went to the Hopkins program as well. And the irony of it too is, even though now I have an MPH from it, I'm actually not practicing with the MPH. Some of the skills I learned in MPH, of course, have served me well in terms of clinical research and some conversations. Plus, it also helps on my CV when people see that I went to Harvard, I guess. But the thing that happened while I was at Harvard was I was still in this process where I was trying to make things, like I mentioned, my thought was when I first got there, when I was talking to my course advisor on picking classes, I was I was leaning and I was trying to pick a lot of classes that were outside of the department. And so thankfully I had a really good course advisor who helped me with thinking about, well, do you really want to choose a path that is going to be fully in the direction of you're going to finish the MPH program and then do PhD and not going to clinical practice? Or do you think that there's a possibility that you would still be interested in clinical practice? And if that's the case, then what else do you need to do, or what else would you want to do while you are here to leverage the resources or things that you have at your
crazier form?
Is there a question? No.
No,
All right.
apologies. I've muted the fellow.
Okay, all right. So I joined the MPH program, and I was in the family and community health track, which also meant that a lot of my work, or like the thesis or the main thesis that was expected was supposed to be oriented around family and community health, or some kind of clinical outcome measures in the community. And so in the process of that, and I'm going to just break for a question. The question here, I think I'll probably leave this one to the end, Alaba, if you can help me keep track. What do you look out for in the applications you review now? If I'm a final year student now wanting to follow the same steps, how can I convince you? I'll leave this one to the end, if that's okay.
Thank you.
Or at least to the end of, yeah, I'll leave it to the end.
Discussion, thank you.
Yeah, and so during the course of the family and community health program, like I said, the thesis expectation was to do some kind of study of a health quality or health outcome measure or something. And so I was the course advisor who I then really became very close to, and then met her daughter and also became close to her daughter. We became good friends. She had a practice, a community health clinic-based practice in Boston. She was a faculty at Harvard, but then she had some appointments at some Boston community health centers. And so we talked about one of the things that she was interested in looking in studying was was outcomes of patients or cancer survivors who were treated at, because the oncology field in the oncology community in Harvard is heavily Boston is heavily centered around Dana-Farber. Also, there's the Beth Israel Deaconess, but it's all very centered around Dana-Farber and the Harvard Medical School. But of course, like patients who are undergoing cancer treatments, there are some people who can afford or who have the opportunity to continue their post-cancer treatments still at Harvard or still at Dana-Farber. But there were a number of people who were referred to Dana-Farber for their treatments by their oncology providers in community health centers around in the community, in the Boston community. So they would come to Dana-Farber for their primary treatments, or they might be treated in clinical trials, and then they would return to their community health centers, many of which were their care was taken over by their primary care providers. So not necessarily oncologists, but primary care providers who had been provided information by the oncologist at Harvard or Dana-Farber about what to look out for, long-term follow-up of those patients, and what to do if there was any concern for return of cancer, or what to do in terms of helping patients to sustained care of cancer survivors who stayed within the Dana-Farber system versus those who returned and continued their long-term care in the community health centers. And again, I emphasize this because this was something that, so again, I went into this program with my own very clear goals and or at least things that seemed very clear to me about what I wanted to get out of it. But I established a relationship with someone who turned out to be a mentor, not just an academic mentor, but also a personal mentor as well. And the direction I took with my work, or the direction, what ended up directing my interest was recognizing that there was something that I had to learn, that I could learn from the experience with this person. I mean, there were other people that I was working with at that time too, or looking at. I was doing some clerkships in some in other community health centers as well in the Boston area. But how I wanted to study this and my having this relationship with her, I decided, well, I mean, it wouldn't cost me anything to make that my thesis project, but then that also meant that I had to learn and really explore what breast cancer was, what breast cancer treatment looked like at that time, right? Not just in Boston, but just in the field in general, and what to look out for in the experience of our patients. And then part of the tools that I used for the thesis also involved doing focus group discussions, which meant that I had to also learn about not just focus group discussions as a tool in general, but focus group discussions in a way that was culturally appropriate, right? Because my experience learning about focus group discussions in Nigeria, in Ife, is centered around a population that is Nigerian and in Ife, right? Versus doing focus group discussions in the US, where you have communities that are, there were community health centers that had a larger African-American community patient population, and there were some that had more of a Latino population, and then white, And so those were also skills that I had to learn, that at the time, again, I didn't see how they were going to be of value to me long-term. But they were value to me then, and it helped me with the thesis. But then also just going through the experience and working with all of those women, and actually interacting with physicians, because I had to talk with physicians in the community health centers and the PCPs, and knowing what kind of information they got back from the oncology providers and things like that, also inspired me to want to go back and continue clinical practice. But now at this time with more of an interest in oncology. And so then after the MPH program, after graduating from the MPH program, I was trying to figure out what to do in terms of residency. But in the interim, I was on a student visa, and making that, in addition to having to get a residency program, also meant that I had to do something during that transition phase. And then I did a healthcare management fellowship at Harvard with the Harvard University Health Sciences, which was I wasn't really using MPH skills, my MPH skills, because like my MPH skills were really directed around family and community health and health programming, right? And for I didn't do a global health, not global health, like more like a health management focus for my MPH. But the healthcare management fellowship needed exactly those, that's what I needed to know for that health, because the program was designed around, the fellowship program was designed around learning the tools for developing programs for the Harvard community. So the Harvard University Health Services was kind of the medical provider for the medical organization for the Harvard community students, faculty. And so those were, so kind of learning how to, with performance improvements, so quality improvement projects, or what to do, or what kind of programs to include in the health insurance package for the Harvard University Health Services community. Those are things that I had to do in that program. And at the time, again, for me, it was more of a thing that I was doing by necessity, because I was doing that transition. But there were skills that I thought, well, I'm doing this for this year, and I'm going on to a residency program, and I thought I would never have to do them, because one of the things that I told myself was I was never gonna have a private practice. I was very unlikely to work in the private practice. I wanted to stay in academia, right? And so why I would need to learn, or what value health management or management in general would add to my life didn't seem very useful at the time, which now in retrospect is something that I rely on very heavily in what I do now. But anyway, so I finished the healthcare management fellowship, and then went on to residency, internal medicine residency for 3 years in Bridgeport, Connecticut. It was a Yale affiliate program. And during that time, at this point, that's where I was applying for the residency. I was very clear in my mind that I wanted to do oncology, and I wanted to do research in oncology that had to do with, and then I thought I wanted to do research in oncology that had to do with outcomes. And so during the course of my residency, I worked with some oncologists in my program to do some studies looking at outcomes of patients with lung cancer, kind of doing some research from the Medicare, the Sears database and the CMS registry, to see what are outcomes of lung cancer patients. Again, kind of continuing with the theme that I'd started in my MPH, looking at comparing the outcomes and kind of quality metrics and financial metrics for patients treated at the affiliate centers of Yale versus those who were treated at at Yale New Haven campus. And then at the time also ironically went back to Johns Hopkins, reached out to some contacts I had made during my application when I was interviewing for that PhD program, and went to do an elective at Johns Hopkins in oncology. And so by the time I was finishing, or by the time I was rounding up my residency and putting applications in for an oncology fellowship program, I had, along the way, picked up all of these different experiences and different contacts and different people who were able to provide me references, between the person who I did my thesis with, a physician who was part of my people I had interviewed during the focus group discussions and kind of reviewing health centers, the oncologists I had worked with during my residency, and the people who I had worked with, or who I had trained with during the elective at Johns Hopkins. And so I applied for a fellowship program. And I mean, as you know, I was invited to interview at some of the programs that I really wanted to go to. And then so when I went to interview at Case Western Reserve University in Cleveland, at the University Hospitals, then called University Hospitals, Cleveland Medical Center and Sideman Cancer Center program, I met with the program director as part of my interviews. I met with the program director, Dr. Marcos de Lima, who had just joined the program actually he had moved from MD Anderson to Cleveland to lead the program. And in addition to leading the program, so he was the head of the transplant, he was the head of the transplant program. And so when we were talking, and so he was asking me about all of the things that I had on my CV and all of the people why he was trying to get me to give him a cohesive story about why I had all those experiences and what I thought I wanted to do with them. And I said, I think at this point, I'm still very interested. I'm interested in oncology, but I still have interest in my immunology, like the things, what first brought me to the US, which is immunology. And so I wanted to have some opportunity to link the immunology and oncology, my immunology desire and my current oncology interest. And so then he talked with me about the fact that he had, at MD Anderson, they had a program, or they had developed a program for cell therapy using natural killer cells. So natural killer cells are a form of lymphocytes that, they're a small subset of lymphocytes, maybe about 10% or so of lymphocytes that are circulating, and are part of the kind of the innate response to viral infections and malignant transformation. And so at MD Anderson, before Dr. De Lima had left, they had developed a platform where they would isolate NK cells from cord blood cells, and then expand those NK cells and then the way because NK cells have this innate response to malignant cells without having to genetically target them. So they had developed this platform, and they were starting some clinical trials by the time he left, using this natural killer cells. And so he talked about how he wanted to develop a program at Case in Cleveland with NK cells. And so that would require somebody with both immunology experience or immunology interest, as well as oncology experience. And he wanted to do it within the heme malignancy, so which is leukemias, which is essentially what the transplant field, at least in adults, is heavily centered around. And I said, that sounds great. And that sounds like something that I would want to be part of, especially my fellowship in Cleveland in 2013. I came there knowing, okay, my focus here is, yes, I'm going to learn. I have 3 years to do this hem-onc program, the combined hem-onc program. But within those 3 years, I need to, working with Dr. Lima, develop a clinical trial, a platform in Cleveland for NK cells in whether heme malignancies or other malignancies. But my goal at the time was I was going to design a clinical trial, right? And but to design a clinical trial with NK cells, first you have to decide on what is your manufacture, like how are you getting the NK cells and how are you manufacturing them or expanding them? Because like I said, they're only a small subset of lymphocytes in the blood, right? And so, we didn't want to do something that was just simply a derivative of what was going on at MD Anderson. We wanted to explore a different source of NK cells and a different expansion platform. But to do a clinical trial like that, I mean, we could partner, and we did identify someone that I could partner to work with on the research side. So a PhD, a PhD who was Dr. David Wald, whose interest was in AML, so small molecules targeting AML, but he was interested in kind of exploring or doing this, exploring this approach with Dr. De Lima. And so he said, you know, you could work with David and see, so that David is the PhD or the lab PI or lab mentor. And so for the trial, I mean, you have to have an IND, an investigator new drug application or investigational new drug application, right? And that IND needs to kind of describe what the manufacturing system for the cells are and then what application. And the protocol, the clinical trial protocol will describe what the trial would look like, who are the patients, how are you administering the treatments to the patients and whatnot. And so he said, you know, work with David and you guys come up with this program. And so I said, well, if I'm going to write a clinical trial, I also need to understand what's going on with the cells themselves. Like, how are the cells being manufactured? What am I writing? How am I describing the manufacturing process? Because for anybody who's reviewing a clinical trial, they need to understand what's the safety of the approach, right? So then I said, you know, like I said, I had no bench experience, and fellowship is not exactly, especially the first year of fellowship, is not designed for you to suddenly be learning new things, particularly in the lab. But you know, I was very determined to write a clinical protocol with a huge chunk or a huge arm of the protocol being something I was ignorant in. I mean, I knew what the NK cells were, and I knew, but I had no idea about what was going to be happening when the cells were being manufactured. So then I said, sure, I'll go talk with David. And so I went to meet with him and said, actually, it wasn't just him, because while we're doing this, we had said, you know, I wanted to learn about the research, so kind of the background research. And so I reached out to a number of researchers at Case then, including someone who was actually in my field on the pediatric side, and he had a program that was designed around kind of T cells. So there weren't NK cells, but he had some experience with culturing lymphocytes, you know. And so I reached out to him and said, you know, I wanted to come and observe. I reached out to a number of people and said, I wanted to come and observe and learn in the lab about how cells are cultured, particularly lymphocytes or things like that. And I mean, of all the people who I reached out to, the only person who said, you know, sure, come along, because was David. Because I said, you know, again, I have no bench experience. And so me coming to your lab to do any work, I mean, what it meant was that me coming to work in their lab, if I was going to do any projects, was going to mean that I was going to be consuming a lot of reagents and things that might, you know, either get contaminated or not, or turn out into the experience that were not successful because I was just learning those approaches. But David had a lab that was really great with, he had had some experience with even training high school students. He was involved in a program at Case then that was centered around high school students doing a summer program. And they would come and learn, like over 8 weeks, learn cell culture techniques or whatever the lab was interested in. You know, so I joined his lab then and honestly started learning cell culture from a high school student who had finished the summer program and then stayed on, because she was really good, stayed on, and she used to come in after hours, and so I'd go in after hours after I'd finished with rounds and things and learn from this high school student, as well as one of the MD PhD students in the lab. And it was a lot of work, but, and again, like I said, I was only doing all of this work just to do a subset, or what I thought was just to do a subset of writing this protocol. But within 3 months, I started designing my own projects with my own experiments with NK cells and started thinking about other approaches to try to stimulate these cells, either to target them, to help them home better to the bone marrow, for instance, or home better to the spleen for patients with lymphoma, or things to try to improve how they work in the tumor, or studying things in tumor microenvironment that might impair their function, and seeing how we could modulate or modify those things. So I say all of that to say that by the time I was done with my fellowship, I had not just finished or done some experiments and some things that I ended up publishing on stimulating NK cells, but I'd also finished writing the clinical trial, as well as worked with the cell manufacturing facility. So the facility that would do the seeing what we're doing and that look like clinical grade manufacturing, or what we call good manufacturing practice under FDA regulations. So I finished my fellowship in 2016, and was at the time I'd gone through the whole process of writing this IND with David for the NK cells. So we designed a platform where we were going to take NK cells from healthy donors, not related to the patients, just random healthy donors, expand those NK cells using a co-culture system where there was a cell line, a leukemia cell line that was genetically modified, again in David's lab, to express a molecule that would stimulate these NK cells to expand rapidly without losing their ability to expand, right? Because as cells expand, telomeres shorten, and then there's a limited number of expansions that they will be able to do in vitro, and even more limited when they're transferred in vivo. And so we had designed this whole platform and gone through the whole IND process, got the clinical protocol ready to go. So by the time I was finishing fellowship, it was like there was no question. I mean, I didn't interview for a job. It was later on even that I became upset about the fact that I never got a faculty interview dinner, like everybody else applying, you'd get a dinner. But I basically was staying on at Case because, I mean, the protocol was going to open and there was nobody else who, on the clinical side, who had the same experience that I did. And at the same time too, when I was finishing fellowship, the person who was the medical director of the cell therapy lab, which is a cell therapy lab that will do all of this manufacturing, both for transplants or for like what we're doing, he was retiring. And so the person, the operations director, the senior operations director of the lab, went to the cancer center director to say, you know, there's the only person on faculty that I can think would be a good fit to replace this person who was retiring is this person who is just joining faculty from fellowship, but she has done a lot of work and has actually worked in the lab, which is the manufacturing facility, in doing this whole, so she understands the process, and she's a clinician, which is a requirement for a medical director. And so I basically joined faculty at the end of my fellowship, not just with a job, but also with a promotion to a medical director position in the cell therapy lab. And so then that meant again, so at that point, right, all I ever joined the lab for was to gain some experience to write a clinical protocol. But then I came out of that experience with 2 jobs, basically, and then a need to understand how to do that second job. And so then I started a whole learning process of, well, I mean, if I'm going to be the medical director of a cell therapy lab, I need to know what it takes to be the medical director of a cell therapy lab. What are the responsibilities as far as maintaining quality standards and things like that. And so then I had to do some studies about the FDA. What are the FDA regulations? What's the Code of Federal Regulations? What does the FDA expect in terms of GMP, or current good manufacturing practice, whether for phase 1 or phase 2, or if you are manufacturing products that are getting close to phase 3, and what is the current quality? What's the current quality expectations? Like, what are the industry quality standards that are expected for academic institutions? And so then that meant me reaching out to the Foundation for Accreditation of Cell Therapy, which is a body that it's kind of like the JCO for cell therapy programs, where it's a quality organization that sets the standards for cell manufacturing, for cell collection, cell manufacturing, and cell administration, both in transplants as well as cell therapies that are non-transplant, so like administering CAR T cells or NK cells or lymphocytes that have been engineered, or either engineered or not engineered, to attack cancer. And so I started looking to see what were the opportunities I had in FACT, because working with FACT meant that I could go to different programs, learn how different programs were structured. In particular, I was interested in how the cell therapy labs are structured. And so I started volunteering with FACT as a cell therapy inspector, as a clinical program inspector. And so that meant that I was able to go for, so all clinical programs that are accredited under FACT, whether clinical program or manufacturing, have to go through a 3-year renewal process of their accreditation. And that renewal process includes having an on-site inspection by a FACT inspector. And so I started inspecting programs for FACT, which of course meant that I had to learn the standards myself, which ended up being a good experience for me, a learning experience for me, because the standards that I was learning, because I would go and inspect programs based on those standards, were standards that I also had to implement in my own program. And so I still inspect, I've been inspecting now with fact for since 2017, and I'm currently on the accreditation committee myself. But every single inspection I do is almost like I learned something new. I learned something about how I should be doing something different in my own manufacturing facility, you know. And so that ended up becoming another thing that I had to learn. But then also being the medical director of the lab, and now I'm currently in my current role here at Fred Hutch, where I'm actually the facility director. So I have more oversight of the day-to-day operations and the management of the lab. The things that I had learned as a healthcare management fellow, which I thought skills that I thought I was never going to have to use, are things that I use now, which kind of seem a little bit incredible, but that's been how things have evolved for me. Some of them were planned, some of them were just, I had the skill sets that I had learned and acquired over the years, and there was an opportunity that was in front of me that those skill sets were applicable to. It's exactly the same thing when I made the transition from Cleveland to here to Fred Hutch. When I came to interview here, I made it clear that, look, I'm only going to come here if there is an opportunity to still be involved with the cell therapy manufacturing facility. And then it turned out they didn't have a facility director at the time, you know, and so I made the transition from being a medical director to being a facility director, because I have the skills I needed to be a medical director, but in addition, I had continued to learn and to develop skills and also be more involved in national bodies with actual cell therapy manufacturing. So and I think, and even now, it's not to say, like, part of the reason why I said learning never ends is that even now there are things that I'm learning that I have to learn. I mean, it's like every single day in the facility, I'm met with a series of some events or series of things that then requires me to learn more things. The manufacturing facility here doesn't just produce cell therapy products. We also manufacture biologic products like monoclonal antibodies and vaccines. And that's something that I wasn't exposed to before. And those are things that I'm learning now. And as I oversee the quality control team, because I'm also responsible for the analytical assays that we use for releasing these products, I'm suddenly having to learn about mass spectrometry and HPLC. We had an HPLC, one of the HPLC units here breakdown, and in trying to reach out to identify new testing sites versus get new HPLC machines and then develop test methods for the HPLC machines, I've had to learn about HPLC in a way that I never would have thought I would have to, you know. And so, and I think that's the experience that for most of us, or for everybody who here, I'm sure even Alaba can say the same thing, that most of us have had this thing where we think we're going to be doing one thing, but then what you're actually doing still requires you to continue to learn something, whether it's clinical practice or leadership skills, which, you know, I thought I would never have to learn, but then now when you have to work as a leader, or you have responsibilities that require leadership skills, then you have to learn those things. And so anyway, so that's kind of like a summary of, and I guess I talked longer than I thought I would, but that's a summary of how I've come to where I am and why I am cognizant of the fact that you have to keep learning, and you have to keep looking out for things that you don't know, that you might not think you need right now, but you will need. And you don't want to wait. Let me see here. Well, the one thing that I will say to finish all of that, of all the things that I have that I've recognized over the years that I had to learn, the one thing that I recognized that I needed to learn and I have not been successful, and now I have come to peace with it, is I'm very good with numbers. If you put numbers in front of with a chemical equation and, you know, calculate the molecular weight of what you need to add to this, how many cytokines you need, how much cytokines you need, I'm very good with that. If you put dollar signs in front of numbers, I become like a fumbling idiot. And so at one point, I decided to try to rescue myself from this ignorance. But I took a course in just basic, and I didn't do badly in economics back in school. I think I took a course, I can't remember what it was. I took some very basic bookkeeping course at Harvard Extension School. I have a deficit in that course. I did not finish it. I'm not kidding. I did the first assignment. And I was like, okay, this is not gonna. So I have one deficit at Harvard right now but anyway.
Thank you so much, Dr. Otegbeye. That's just a brilliant run through of an amazing journey. And listening to you, I started making some notes. There were some key moments that really stood out for me. One was volunteering to do something when you actually want to learn. Now, at that moment, it might look like there's no benefit, there's no gain, but volunteering allows you, puts you in a place where you can really learn some things for free. In fact, because you are volunteering.
And network with people for free.
And network people for free. Yeah. The other one is you're such a self-driven, self-challenging person. You knew the next level. You knew you had to go after something to get to the next level. And that's more being very self-driven and more like how would I put it? It's not just self-driven, it's being self-aware of where you need to be and what price you needed to pay to get to that point.
Yeah.
Yeah, so that's, and then going after the things you need, and then network seems to be so important. And Absolutely. The fact that no knowledge is wasted, things you never thought you'd use are suddenly coming in handy at some point far later down the line. Yeah. On the dollar issue, the only thing I understand about that sign is when it lands in an account. Yes, that works really well. I'm
satisfied when I see my salary coming at the end of the month.
That's the only thing I need to understand.
Anything else, But I will emphasize though with the networking thing is that it's not just about networking, right? It's that you have to think of networking in terms of you have to give something to the network, right? So if you're volunteering, you're giving something. If you are, and the people who you're reaching out, who you're networking with, they have to see that you bring some value to them just as much as they give some value to you, Right. And so yes, of course, there are people who are always motivated to help and motivated to, help promote others, but then they need to see that you are bringing something or you're committed to bringing something to that relationship.
Absolutely. Thank you very much. Demilade has made a comment. Oh, he's after money. This boy is always after money.
I know. I saw.
He's after money. There are a couple of questions there because I was just thinking, if I was a student now, just finishing from IFE, and I want to, let's say, copy your footsteps or try to walk in your footsteps. That first application to a master's degree, a PhD program, what exactly do I need to put in it that would actually get people interested in interviewing me? That would first give you the first breakthrough.
Yeah, and I think there was a question on there about what do you look out for the applications that I review now from the final year? Yeah, exactly. Yeah, so I think being very thorough in your review, again, even though many times a lot of this you're still kind of doing like an expedition, especially making that transition from medical school, especially in Nigeria, to the US, right? They're trying to like put out all your, but it's not just like people don't want to see. I don't want to see somebody send me, and I get those requests, right, where people just like randomly find email addresses of people at Fred Hutch or whatever, and then you get this email blast of I'm finishing and I want to come and do work in your lab, right? That doesn't tell me anything, right? But then if you're putting in an application for something and then you're applying to a program and you say, I'm interested in doing I'm interested in pursuing a master's program, or I'm even going to come do a postdoc or be a research student in the lab. Mm-hmm. And you're saying, I've identified this lab and this is why I'm interested in joining that lab. Like I said, when I sent in my application, I was very clear about the fact that I'm interested in immunology. I think I put something there about immunology, about infectious disease, and how I remember that I put something about Burkitt's lymphoma, about what about the relationship between malaria endemicity and Burkitt's lymphoma was something that caught my interest. At least tell a story that shows that you have put some thought into why you're reaching out to this person or why you're reaching out to this program that is beyond the fact that I need a reason to get a student visa. And so, no, it's true. I am not saying that to be, yes, at the end of the day, the reality, and people know that too, like the reality is that you want to at least get your foot into the door and then start to explore what you can do. But many people are trying to get their foot into the door, right? And so why am I going to commit my time to you or to helping to promote your application when all you've sent in is just the fact that,
flimsy.
Yes.
Okay, thank you. And the other question there, before I leave the floor open to everybody else, is, let's say I'm just finishing in IFE now, and I want to have a taster, an experience of what working in an immunology lab is like, just so I can see what it's like. Would there be a chance if we got in touch with Dr. Otegbeye to say, are you able to take a rookie student from Nigeria to come and just understudy you for a couple of weeks or a couple of months?
Okay, so right now my lab is, the distinction between me and somebody, so I can look out for colleagues who have their own like research labs. My lab right now is not a research lab, and so I'm very limited in the kinds of people that I can have join the lab or come observe the lab. It's a GMP lab, where it means you even being in the lab or in the facility itself means that you're going through like training in GMP and gowning and all of those, because we're working directly with clinical products, right? And so even now we've been talking about trying to develop some programs where because there are some colleges here that are trying to train students for working in GMP facilities, and so we're trying to design programs for that. But it's a little bit more complicated getting people into my lab, for instance. But there are programs, and again, all it takes is looking for. I think most programs or most colleges or most medical schools have some kind of internship experience or summer. Like a lot of it, to be fair, are centered around undergraduates or colleges here in the US, and particularly now where there's a huge shift to trying to improve diversity in academia, where there's a lot of focus on trying to get students from HBCUs. So HBCU colleges, primarily colleges that have a heavy African American student population. But again, all it takes is looking out for, there are programs that have, and then even societies. So not just, the other thing is, it's not just the universities or the colleges. So different societies, so American Society for Transplant and Cell Therapy, the AACR, which is the American Association for Cancer Research, ISCT, even I'm sure cardiology, a lot of societies have programs that are designed for. American Society for Hematology is one great example, where there are programs designed for for students in developing countries to come and then they already have programs that they've identified and mentors in those programs that will take visiting fellows or visiting, and the fellows designation has different levels, right? Visiting fellows that can come and train in those programs. So that's another thing to look out for.
All right, brilliant, thank you. Is there any other question for Dr. Apart from Amaka saying not a G?
Amaka, I see you.
Is there any other question for Dr. Otegbeye before we round up today? I can't see any hands up. Feel free to unmute yourself and ask a question if you've got one. I see Demilade there. He actually left money to come to this. Thank you, Dr. Demi, for not chasing money for the last 15 minutes. Okay, so I think at this point, I'll just say a huge thank you to Dr. Otegbeye for spending the time to tell us about this amazing journey she's had. For those who knew Sade in school, it's called quiet, competent confidence. That's the way I'll describe her. Quiet.
I think that's generous. Some people describe it other ways that are not as flattering, but so thank you.
Not that flattering. But generally, she was quiet, she was confident, very competent, and extremely brainy. She's one of those guys we looked up to in med school. And the fact that she could even wrap her head around the immunology we were taught, the way we were taught in those days, already shows how good she is. So a huge thank you to you. Thanks for taking the time to join us today. I'll stop the recording now, and please feel free to speak freely afterwards.